A lot of the antidepressants because they're activating. They'll make the mania part of them worse. So here, the only antidepressant that's recommended is fluoxetine, and it in combination with olanzapine, which is Zyprexa. So that's a second generation antipsychotic. So the combination of those. But backing up just a little bit. The kind of the general things to remember, one is clinical assessment here is important. What brought it about? Did they stop taking medicines? Did they start taking something new? Are they using illicit drugs? Are they using alcohol to a greater extent than they were before? Did they stop taking a medicine, or have they not, is the dose not been advanced? Those would be important. Assessing risk of suicide for these patients. Tapering off other agents like benzodiazepines or sedative hypnotics if there's something that you think is contributing or precipitated. And then just the basic good nutrition, sleep, exercise, good health. So the fluoxetine, olanzapine would be a preferred. There is a combined product on the market called Cymbaxa, and it's listed there for you. Using antidepressants is controversial because they can cause a switch. So they can switch the patient to mania. So you'll see most of the drugs we're going to talk about are not antidepressants for this acute event. Lithium is very effective, but it's slow. It's quick with mania. When you treat a patient who has an acute manic episode with lithium, it is a quick action. But the antidepressant effects of lithium are much slower. I think 6 to 8 weeks. So usually they're going to have to be treated with something else in that time when you're getting the lithium is taking effect. Another really good drug in this is lamotrigine, and it has a low side effect profile for the most part. Most of the time you're not going to use it with valproic acid, so this is another one to consider. Slowly titrating usually decreases the risk of that rash that we're concerned about. Lamotrigine can be used with lithium. It's very effective. Valproate and carbamazepine also can be used. Carbamazepine is usually added to an antidepressant or to, again, prevent the switching to a manic. Looking on the next page, page 8, the second generations that have been used, or antipsychotics that have been used, are quetiapine, lurasidone, which is Latuda, and olanzapine, again, Zyprexa. So you see it's the similar, you're seeing the same ones over and over again. Most of the time it's a quick titration, so within a few days. This is well, they say 2 to 7 days, so within the first week. Latuda, just note with it, is it requires, it's really upsetting to the stomach, so they recommend a pretty good meal that it be taken with to decrease GI side effects. And then that patient management, again, is just kind of a summary of what we've already said. Questions about the acute? All right, let's switch over to lithium. Really interesting drug. Let's see. So I don't know if I remember telling you part of this. I don't know if I told you the whole story. So the first years, or the first group that came through, when they got to psych, they said that the EOR was mostly on side effects. So that's why I did a separate handout on lithium, because it has so many of them, and that's why you also have separate handouts on the side effects for the antipsychotics, which we'll talk about next. So that's why this one's kind of a little bit different. So on page 2, so Dim, we do not know the mechanism of action of this drug, why it works in psychiatric illnesses. It may be gene modification, it may be a neuroprotective effect. It's in that same periodic table row with sodium and potassium and calcium. So it's one of those elemental metals. It's very effective for acute mania, acute bipolar depression, maintenance. It just has a lot of side effects. Clinical effect, 80% of patients will experience an abortion of the acute manic. 6 to 8 week delay we talked about for antidepressant. It's prophylactic in the majority of patients, reduces suicide risk. More effective, as most of the drugs are, in patients who have fewer episodes, history of good function, good response. It can be used with other psychotropic agents. It can be used to augment the antipsychotics. Contraindications to use. Do not use them with calcium channel blockers. You get an increased risk of neurotoxicity and bradycardia. If the patient has to undergo ECT, have you talked about that? Electric? Okay. Then they need to discontinue the lithium before and restart it several days after the last treatment is completed. Workup. Here's what you need to do before you start somebody on lithium, and it'll become apparent as we go through. Urinalysis. Drug is very nephrotoxic over time. Serum creatinine and BUN would go along with that. TSH, it causes all kinds of thyroid problems. Calcium, EKG for those at high risk for cardiovascular disease, and a pregnancy test. It's very teratogenic. Dosing and monitoring. So the good thing is that this drug has therapeutic dosing range of 0.6 to 1.2 milliequivalents per liter. You will see some other references that will list it as 0.8 to 1.2. But a lot of folks will like to drop it down to that 1.6 if people can tolerate it and respond, because your side effect profile is less. Usually we start out with dosing it 2 to 3 times a day until the person gets stable, and then convert them over to a once a day. A lot of the side effects will go down with once a day dosing, and there is an extended release product that usually helps with side effect profile. Steady state's got a short half-life, so within 5 days you're at steady state, so you can start to see response. Serum concentration should be drawn 12 hours post-dose. So usually if they're doing it twice a day, you draw at the trough right before the next dose. Has a large distribution phase, so you want to get past that when you're drawing this level. Monitor, so this would be an ongoing monitoring all the time. Sometimes the toxicity will look like a aggravation or an underlying worsening of their mania or their depression. So anytime you see that, always check a a lithium level, because it could be that they're lithium toxic instead. Okay, acute side effects. We're going to divide them into acute and chronic. So on the top of page 3. These are initial dose-related. So they usually will go away, or you can manage them better with lowering the dose, taking them with food. Use an extended release product will help with a lot of these, or dose them at bedtime. Acute effects: nausea, tremors, polyuria, weight gain, loose stools. Cognitive impairment. So you see increasing apathy, decreased creativity, change in verbal learning, memory, concentration. Dose-related, dividing up the dose will help. That's why we usually start off with 2 or 3 times a day, and then consolidate it once they're on it for a while. GI distress, so nausea, vomiting, diarrhea, dyspepsia. Have them take it with food. Or lower the dose for each of the subsequent, divide it up, or switch them over to the extended release. That usually will help a lot. You can use antacids to help, antidiarrheals, until their gut kind of adjusts. For diarrhea, you can switch from the tablet or capsule to the liquid. So lots of just changing dosage forms, duration, the number of times you administer it, or use an extended release. So it causes a nephrogenic diabetes insipidus. Now, I know we haven't got to endo yet, but this is related to ADH. So they get you've inhibited that ADH, and so they pee a lot. Usually the first sign is nocturia. When you get to DI and endo, it'll be the same thing. So they just can't go through the night without wetting the bed or wetting themselves or having to get up and go to the bathroom a lot. So they lose the ability to concentrate the urine. So with that, what's the specific gravity going to look like? Low. It's going to be low. So you look at their urine, it's the color of water. So it's they lose that concentrating ability. And low osmolality and polyuria, they pee a lot. 3 liters a day is a lot. Okay? Every time you go, it's probably about 250 mils. And so you can think about how many times, so that's about 12 times a day or more. Okay. So lithium is accumulating in those collecting tubes. They become resistant to their own ADH. Okay. So diabetes insipidus can be central. It can be due to the ability to produce ADH out of the pituitary, or it can be the kidneys don't respond. So here the problem is they produce ADH, their kidneys will not respond to it. So that's why we call them nephrogenic. So you have to, if you can take them off the lithium and move them to another product, that will solve the problem. It will reverse. If you can't stop it, you can use amelioride, which is a diuretic, potassium-sparing diuretic, and it blocks sodium channels. So when it's present, then lithium can't collect in those tubules. So it will restore some of that concentrating ability and reverse the symptoms. The earlier you do it, the better off it is. So recognizing it and treating it is important. So monitor their lithium levels. Diuretic-induced volume depletion will make them more likely to get lithium toxic. So using a diuretic with lithium is always a little bit iffy. Fluid restriction is not recommended because dehydration puts them at risk for lithium toxicity. It can become a permanent, irreversible defect, so that's why you want to catch it early and treat it. Questions about that? Fine hand trimmer, here we go again. Looks very similar to an essential trimmer. Very common, 50% of patients. So you might keep this in mind when your people come in with a trimmer that you don't know. Lithium is a very common drug cause. It's symmetric, upper body, limbs, dose-related, serum concentration. So get a serum concentration. It's not progressive. Things that aggravate it, just remember back to when we talked about essential tremor. Anxiety, caffeine, stimulants would tend to make it worse. Same thing here. It usually resolves over time, but it can be a sign of toxicity, so draw a concentration. Management, get rid of the aggravating factors if you can. Reduce the lithium dose if you can. Rule out lithium toxicity. Really important, lithium toxicity is bad. So you always want to have that in your mind, is that could this be that they've got too much lithium on board? You can move from a long-acting to a short-acting. Try a different lithium salt. So it comes as a carbonate salt and a citrate salt, so that may help as well. Or you can add a beta blocker. So think essential tremor, that was one of our drugs of choice, right? And you all got that right on the test. Mm-hmm. Okay. Dr. McNeil wrote that one, I did not. Muscle weakness and lethargy in about 30% of patients. So those are the short term. So nephrogenic, diabetes insipidus, and then the GI side effects, and that fine hand tremor. Okay, those are acute. So let's look at the long term. Long term, think 2 organs, kidneys, thyroid. The parathyroid can and the heart can, but they are not as common. Renal toxicity, very common with lithium use, so it can happen short term, it can happen long term. Okay, we talked about the nephrogenic diabetes insipidus, so that could become a chronic problem if not treated. There's also renal changes that can occur, so they can develop glomerular sclerosis, a tubular atrophy, or interstitial nephritis. Risk factors: the longer you use it, the more likely it's to occur. The cumulative dose. So again, lower doses is what we're going to aim for because that decreases the cumulative dose or the time to get there. And then older patients. So they've already got kidney, probably insufficiency or decline in function because of age. Renal insufficiency is mild, but it can progress to end-stage renal disease. Okay, so that means dialysis. So if the lithium is discontinued, they can recover, but not always predictable. Impaired water resorption, increase in serum creatinine. So monitoring renal function. So now you know why your baselines are so important, and then monitoring periodically would help to pick that up. Lowest effective dose, once daily dosing, adequate hydration, avoid toxicity. Monitor their renal function. So the urinalysis, you can get your specific gravity off of that. BUN and serum creatinine every 2 to 3 months early on, and then at least every 6 to 12 months as they're on it. Unless they've got renal toxicity, you would do it more often. All right, thyroid disease. So it does two things. One is it can cause goiters. I know we're a little bit ahead of ourselves because of endo. And hypothyroidism. So you know the thyroid is here in your neck, spans right across here. Okay. So lithium concentrates so it likes to get into an organ and just set up house. So it concentrates in the thyroid and interferes with hormone synthesis. So your thyroid gland is under the control of your pituitary, right? So the pituitary is under the control of the hypothalamus. So you've got the TSH produced by the pituitary is going to direct the thyroid to produce hormones T3 and T4. That T3 and T4 feed back to the pituitary and tell them when there's enough. And so then the TSH goes down, thyroid doesn't make as much T3 and T4. Okay. So T3 can interfere with hormone synthesis in the gland. And it can also it can aggravate or alert the immune system, produce antibodies. So when we get into thyroiditis or thyroid toxicosis, that's often because you got antibodies produced that then destroy the gland. And then it dumps a bunch of thyroid hormone. So baseline, you want to obtain a TSH. I'll tell you that in people who have histories of thyroid disease prior or have family histories tend to be more at risk for this. So you're going to want to monitor those thyroid. If something comes back abnormal, you'd want to get the antibody test as well. So antithyroid peroxidase is one of the antibody tests that you can order. So a goiter. So this happens in up to 50% of people. So a goiter is that tissue getting bigger. So if you if the pituitary gland is putting out more and more TSH, then the thyroid gland responds by getting bigger. So that is where the goiter comes from. Diffuse meaning it's not nodular; it's the whole gland. So instead of it being one lobe or one side, it's usually throughout the gland. Now, so when we get to talk about thyroid and goiters and nodules, one of the things we first do is we scan them. We do an ultrasound. If we can identify where the growth is, then we can do a fine needle aspiration. So that's what that FNA is. And then they go in, remove a little bit of thyroid, and they look to see what is it, cancer, benign, and then it tells us what we need to do about it. Levothyroxine, which is T4, can be given to reduce that output of TSH from the pituitary, settle the gland down, and the person can be managed that way. Hypothyroidism occurs in 50% of patients. So always keep thyroid as a primary problem in most patients are going to end up with some kind of thyroid problem on long-term lithium. Usually it's subclinical. So what does that mean? So what's subclinical mean?
Like you either don't really like see it or notice it or not symptoms or it's not.
So how would we know it existed?
No clinical symptoms.
No clinical symptoms, but how would we know it exists?
Routine.
Lab. Lab will be abnormal, but the person has no symptoms. So they could have slightly elevated TSH, T4 at the lower end of normal, and you ask them questions about hypothyroidism and they're like, nope, 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 nope. Okay, so that's subclinical. Some people will go on to get symptomatic. So symptomatic would be they continue to gain weight. They're lethargic, more lethargic. They don't have energy. Those would be common symptoms or complaints of hypothyroidism. Usually occurs early. More common in women, older women, in older patients. Don't have to stop the lithium. You can treat them with T4, so you're going to replace what they're not able to make. If you stop the lithium, reassess the T4, because then you can make them hyperthyroid if you leave them on too much. And it is reversible. So very, very common. So the parathyroid, where's the parathyroid? It's in the thyroid gland, embedded in it. Each lobe has, you've got 4 little spots. Pardon?
It's like on the pictures I was shown as like little balls.
Yeah, they're just little tissue islands in the 4 quadrants of the thyroid. Okay. So lithium can cause hypercalcemia. So elevated parathyroid hormone will then cause the bone to release calcium, right? And calcium levels go up. So you would monitor calcium levels in patients on lithium. So it can cause a hyperplasia of the parathyroid. Think about it like what it does with the thyroid, and we're putting out more parathyroid. This one's a little bit harder to manage. If you can get rid of the lithium, then that will solve the problem. Parathyroids will eventually go back down to normal. But it can lead to severe mineral loss. So in women, you're going to want to be monitoring that in particular. Both men and women. Women are probably going to show up faster. So doing bone mineral, what is the thing? You can tell us the end of the density. Yes, thank you. Bone mineral density. In the forearm of women under 45, is a pretty early time to do it, but keep that in mind, is monitor calcium, monitor their bone density. The fourth one is cardiac, so EKG abnormalities can show up with lithium. So T-wave flattening, or they can invert, AV blocks, bradycardia. So in people who have pre-existing heart disease, get a cardiology consult. Others, these are very uncommon. So reversible leukocytosis and derm, usually don't see those very often. Neurologic can occur, especially with long-term use and also with toxicity. Weight gain is common though, more than 10 kilos. So how much is 10 kilos? Like 22 pounds. It's a lot of weight. Lithium toxicity, very toxic in an overdose situation. So when the serum levels are greater than 2, so the upper limit of normal is 1.2, so you're talking about 2 milliequivalents per liter. Again, symptoms, GI, coordination, so neurologic toxicity starts to show up. Hand tremor, unstable gait, slurred speech, muscle twitching. Cognition goes down, so it's a neurologic, mostly toxicity. What predisposes people? Sodium restricting. So people have hypertension that have been told to be on a low salt diet, advise them to liberate. So you can see why it becomes a problem in older people. They might sodium restrict, they may think that's healthy. Dehydration, so their thirst drive goes down. Dehydration, nausea and vomiting, more electrolyte loss. Older age, liver disease, excessive use of caffeine, So that would be the more diuretic effect that's working against them. It's an ER treatment, stopping the lithium, gastric lavage, IV fluids, hydrate, support the kidneys, the neurostatus. You may have to do dialysis if the levels are extremely high. Okay. Questions about that? Now you know more about lithium. Interesting drug. So let me tell you about the things that I have given you. So you have a handout that we're going to go through today on schizophrenia, on antipsychotics. You have a table that looks like this. It says monitoring antipsychotics. A couple of things that have happened in the last few years. People who take antipsychotics have a higher risk of dying than people who don't take them. So the FDA came out with a warning, one of their black box that said, particularly in older people with dementia who take antipsychotics have a 1.6 to a 1.7 times the risk of dying as someone who doesn't take them at all. Okay. So why is that? Well, they cause lots of metabolic problems and cardiovascular problems. So the Centers for Medicare and Medicaid came out and made these stipulations on psychiatric hospitals. You must monitor patients who are on antipsychotics, and you have to report it. You have to send us in the data on your monitoring for anybody who is released from the hospital on an antipsychotic. Okay. So the monitoring is quite extensive. So that's why we're going to go through these. So I did you a table based on the adverse effects, what monitoring needs to be done, and how do you manage the adverse reactions. So you'll see there's the metabolic, or at the top, the weight gain, diabetes, lipids, and blood pressure. Then there's the heart, QTC, orthostatic hypotension, increased mortality. Sexual dysfunction and prolactin, that's often go hand in hand. On the next page, anticholinergic fall risk goes up with people on these agents. Neuroleptic malignant syndrome, very similar to serotonin syndrome. Seizures. Then you've got agranulocytosis and hypersensitivity. Then there's ocular and cataracts, liver toxicity. Last page are the tardive dyskinesias and the extrapyramidal. Lots of stuff. Okay? So that's what this table is for. The color chart is a comparison of the first and second generation antipsychotics. So the first generation, we're the first ones to come out. Everything up to about 1989 is considered a first generation antipsychotic. Starting with Clozaril when it came out in 1989, and all the ones beyond that are considered second generation. The line that demarcates them is very dim. There really is not a lot of difference between them except with EPS and tardive dyskinesias. So the second generation tend to not cause as much extrapyramidal symptoms or tardive dyskinesia. That's their real true difference. So that's what's driven a lot of people towards using the second generation. But their metabolic and their cardiovascular side effects are pretty high, and we'll go through those. So you've got an offset. You don't see that so much with the first generations in terms of metabolic, but you do with the second. So those are listed. So I've got under first generation, second generation. I've tried, where I have that information is to indicate what are greatest offenders are in that last column. Okay. That's that. Now, you may not find that these are of any help to you. Now, the monitoring will be. The other one is, you may find it helpful in this course or not, but next year I think it will play out more. The last two are kind of for your information only. It is the kinetics and potential for drug interactions in one of the first one, and in the second one, it's the dosing and the different formulations. So these drugs have lots of different ways to get the drug into the person, and so that's I think will be helpful there. So this one's just kind of for your information. Okay, look, I didn't get the objectives done. I redid this yesterday. I just did not get the objectives, so I will work on those tonight and send them out. I apologize for those of you who like to have them and go through. I am sorry. So in the very beginning, the first and second generation